Good afternoon. So today for our extended education series, so today we have decided to talk about a common topic of kidney stones. Today as a panel we have Dr Ravish I R, who is a lead consultant urologist in Aster RV Hospital. Dr Veerabhadra Gupta, who is a lead nephrologist, Aster RV, as well as myself, Dr Nandakishore, consultant urologist in Aster RV Hospital.
Sir, today's topic is kidney stone. What is a kidney stone as a layman could understand?
Okay. So kidney stone, for the information, so it is an aggregation of all the minerals, whatever which has been decided has been to be thrown out from the kidney, which will get aggregated and form as a stone. So that is the kidney stone.
Okay. It's not the stone which has eaten or something.
No, it is not related to any of the intake.
That is the usual common myth which is there among the public. How does it happen, sir?
Okay. So whenever we are talking about the formation of the stone, so whatever we eat, whatever we respire, whatever we breathe or apply, it all has to go to the inside the kidney or inside the body, and the body has to throw it out as an impurity from the kidney. So kidney itself purifies the blood, at least the whole volume of the blood will go through the kidney at least 5 times in a day. So when it goes through 5 times, it filters all the impurities and it throws out. So whenever a particular person does dehydration or anything, all these impurities have got time to attach to each other and form as a kidney stone and gets thrown out, usually and eventually from the kidney down into the bladder.
How common is it, sir?
So when we talk about the kidney incidence, it is actually seen as 1 in 1,000 of as a population. Compared to the propensity or the lifetime risk, like in females it is around 5 times, whereas in males it is around 13 times as the lifetime risk of having the kidney stones. So when we are talking about only the adults, even the kids can have, or the children can also have the kidney stones. So it can come up to the level, it can start even at the age of 6 months, and we have also treated at 6 months or 1 year old kids having kidney stones.
Who are at risk for all these kidney stones?
So kidney stones are basically more common in men compared to women. So men will be, I don't know, the reasons for are varying, but however the males are having more incidence of having kidney stones. Dr. Ravish, would you like to add any pathogenesis of kidney stones, how it actually forms?
Than pathogenesis, I would like to tell you the basic simple principles which the people can understand is called hypersaturation theory. What is it? It is nothing. See, if you take a half glass of water, if you can put in 2 teaspoons of sugar in it, it will dissolve. If you try to put in 4 to 5 teaspoons, there are some always aggregated crystals collecting in the bottom of the glass. These are the same principles which happens in the kidney. And if in the same half glass of water is more added to the half glass which is there, the whole sugar dissolves in it. That means the more we add dilution, the more the stone formation decreases. This is what the basic principles we should try to understand in stones. The other principle is infection and sepsis. Whenever there is an infection or something, there is a raw area being created in the kidney. This raw area is always sticky. It becomes like a glue sticky, a raw area. See, if a wound is in the body, you see the serous discharge there which becomes sticky. And these sediments which are there collect on those sticky areas, and on that again sediments start collecting and become stone form. This is one more thing. The other one is diabetic induced patients or infective induced patients which causes infection will also cause stickiness in the mucosa. This causes aggregation and sedimentation of stones in this, leading to stone formation. So basically, if you take all these things and see, if there is stickiness also, if there is sedimentation, it is the crystals which have to sediment there. So if you don't let the crystals to form, if there is an attachment and dilution, then there is no crystals formed. If there is no crystal forms, the stone formation is not. So please understand the basic principles is that the more the dilution, the less the stone formation is there. I can't tell you definitely this patient needs 2 liters of water per day and he will not form stones, or he needs 2.5 liters of water per day not to form stone. Each body is different. For this, I would like to say, see, What is that we basically look at is 2.5 liters of urine output per day. This is the minimum basic required. I can't calculate how much urine is passing. So we think 2 liters of urine output per day. Our body excreta, the sweat secretions, everything will averagely come out to 600 to 700 ml per day. So we say 3 to 3.5 liters of fluid per day is required to keep us normally to a hypersaturation level where the hypersaturation doesn't occur. So we say 3. Some people might need little more water, are people who sweat more, who do manual labor work. So we say according to the type of labor, the work he undergoes, we have to calculate the water output. If he's an office worker, might be 3 to 3.2 liters is enough. If he's a laborer who's working, sweating more, that means he might require about 3.5 to 4 liters of water per day. So we roughly calculated that. So the main thing which I say, fluid is what is required to decrease the stone formation, except in congenital anomalies or uric acid defects where the stones are formed.
That's a very important point you have highlighted, sir. So it's usually seen in the people who really do outdoor works without proper hydration.
Yes.
So that's usually seen in the population with those who work in a real estate, building construction, or in the surgeons who are in the OT for a very longer time without having
Good
hydration. So
The other point also I would like to put out, and if you see the demographies, you can see the hot areas, which are the humid areas, which are hot, are the areas where the stone formation is higher. It is lesser in the areas where it is slightly colder, and this because their sweating is higher, but they don't drink water which has been sweated out. So the sedimentation occurs. So we have to calculate all these things before we say. Dietary constitutes only 2 to 5% of these patients. And dietary acts once when the stone is formed. From today, if I'm going to say diet, I'm going to this is not going to form, it doesn't work like that.
you also mentioned that some of the congenital abnormalities also will lead to. How often kidney stones are seen in the
So about 5 to
children
10, 5 to 10% of the patients who are children, we see about 30 to 40% of them forming stones due to congenital anomalies. If you see the elderlies, the congenital anomalies are usually deleted because they have not formed stones until that time. So we see in children, if we form a stone, we have to congenitally evaluate the metabolic defects of the child, if anything is there for stone form. In adults, we usually don't do that. Next, we always try to think about a stone analysis which can be done to know the type of stone, and then try to have some minimum dietary restriction which really doesn't help much. A minimum dietary restriction with fluid more is what is at last required.
So does that run in the family?
Yeah, definitely it runs in family. It is up to the tune of 25%. So any parents or anyone of like that, so the incidence will increase in those who are having already a family stone. As well as he has already mentioned, the geographical location. If we are seeing a belt like Gujarat or Rajasthan, where the temperature is so hot, each one, at least one person in the family will be definitely having. Whereas when you come to the south, we have very less compared to what. So geographical incidence is also changing.
So patient has a kidney stone. How does he know, or how does he present to the hospital or
Symptomatology. So the symptomatology starts like when if at all the kidney stone is inside the kidney, so it can be silent. So it can be silent until it becomes a big size, or even if the smaller stone which is attached inside the kidney, so doesn't bring about any pain. But once it starts trying to pass out and it comes out of the kidney and wants to go to the bladder, there is a point of time it brings about blockage. When it brings about a blockage, it gets pain. The pain can be isolated to one particular region, but when it is traveling, it can also radiate towards the testicle, towards the penis, or towards the leg. As well as it can bring about vomiting sensation, and if there is an infection associated, there can be fever. And if the stone nature is having a spiky this thing, and it brings about an abrasion in the kidney, ureter, bladder region, any point, so it can have blood in the urine. These are the common symptoms how the patient can have. So, which are the times when a patient can, when these symptoms are more pronounced, like severe vomiting, or the pain is not coming down even in spite of taking some small medications, painkillers. So these are the patients when usually they come into the hospital and we will start evaluating them.
in a nutshell, if patient has a very severe symptoms, all stones need not be symptomatic.
Yes.
So in a nutshell, if the patient has a fever, chills, or any blood in the urine, very severe pain which is not refractory to general medication, should probably approach it up. That's what.
Yes.
Okay. So how does you manage or how do you diagnose the renal stone?
So any particular patient who comes with all these symptoms, so first of all, we usually do a urine test to see whether there are any pus cells or any red blood cells or any changes in the urinary system. Or we send the urine for culture to see if there is any infection. So then the next thing will be blood test. Blood test basically we would like to know the complete blood count, whether there is increased white blood cells so that the infection is too high. So whether how should we plan our treatment. And next into the kidney function test. So how does the kidney function? Whether the kidney is already been injured or the kidney function is normal, whether can we give some time for the patient to treat. These the things which will be given by the infection. The best thing will be the ultrasound. When we see the ultrasound, the kidney stones will tell us whether the kidney is blocked or there is no blockage because of the kidney. The gold standard of identifying the stone will be a CT scan. So plain CT will tell us the size of the stone, the location of the stone, where stone is exactly located, and the integrity of the stone. If the integrity is something what we call maintain as a soft stone. So we know very soft stones are not being able to manage with something called a lithotripsy. Very hard stones, we know what should be the approach. So this also will dictate us how to tackle these stones. So coming on to the management, how it has to be managed. It can be managed either by a medical term or a surgical management. The surgery management, Dr. Ravish will be enumerating us how we can manage the stone surgically.
See, stones. First we have to see where the stone is, the size of the stone, the location of the stone. Is it associated with infection? It is not associated with infection. Or any other abnormalities of anatomically identified there for us to have an approach. So first we have to see this. So where Dr. Nandakishore has told us, CT scan is the dictum in some cases. And yes. After the CT, I find out the size of the stone, the hardness of the stone by knowing the Hound speed and the location of the stone. Then I would like to plan my surgical techniques. See, if the stone is a smaller stone, it is below 1 centimeter in size, it is placed in the calyxes or in the pelvis, then my treatment mode differs. If it is between 1 to 2 centimeters, again I would like to use 2 different techniques which will be available. And the third is the very huge stone about 2 centimeters or 2.5 centimeters. These smaller stones which are just below 1 centimeter size or below 0.5 centimeters in size, I would like to wait and watch by giving hydration and telling them drink a lot of water and alpha blockers with it also. And we would like to give drugs which will increase the motility of the ureter to throw the stone out. These are for the kidney stones. Okay, if the stone is about 0.8 to 1 centimeters or 1.2 centimeters in size, I would like to do a procedure for it. It might be non-invasive or invasive. See, in a non-invasive procedure which we call ESWL, that is extracorporeal shock wave lithotripsy. This is nothing, an ultrasound wave being sent through the ultrasound probe and breaks the stone into the fragments. The main thing by using this technique is the Hound shield should not be very high. That means it should not be a very, very hard stone. Then the chances of breakage is low. Or the stone is a bigger stone, more than 1 centimeter or 1.2 centimeters, where we don't recommend ESWL. The positivity of ESWL is that it is a non-invasive method. The patient comes and sleeps in the OPD for 15 minutes under the machine, shocks are sent, the stones are fragmented and they go back home. The negativity in this is these small fragments might come and stuck in the ureter. Most of the fragments pass off. If the fragment gets stuck in the ureter that doesn't come out, then we might have to do a ureteroscopy, an invasive procedure to remove this fragment. This is the downfall of this procedure. But this works well with the softer variety stones. In children, it gives you wonderful results because the stones are not really hard type, they are the soft type. It breaks into smaller fragments and it passes on. See, it is not the ESW machine which is very good, which is required. It is also the technician who focuses at that point and breaks it into smaller fragments. See, and the next is, if the stones are slightly bigger in size, is more than 1.2 centimeters in size, or this, and it is present in the kidney, then I would like to do a technique called RIRS. that is retrograde intravenous surgery. This technique can be done best with the help of a flexible scope and a laser. Here, the scope goes through the urethra to the bladder, from the bladder to the ureter and up to the kidney. This flexibility of the scopes lets us mold in whichever calyx the stone is, go there with the help of a laser, break it into fragments. We have to break it into smaller fragments that the powders come down with time. But only one thing we have to remember, if the patient has got severe infection with chills and this, we would like to just put a stunt and come out and revisit the patient after a week's time or 10 days time to do the ureteroscopy. That is flexible ureteroscopy. If the stone is just below the pelvis or in the ureter, I would like to do a ureteroscopy, semi-rigid ureteroscopy, where I break it into fragments and pull down the fragments down. So that is called RIRS. This is URS. See, one more thing, if you do an URS and RIRS, there are some conflicts saying that should we put a stunt or not put a stunt. It depends on the type of infection the patient has got, or the type of hard stone, how much of time we are in the ureter, how tight the ureter is, and all these things should be taken into consideration. Should we put stunt or not put stunt? The other technique is for huger stones, bigger stones, more than 2.5 centimeters in the kidney, which are present, which are silent stones, which in a flexible scope can be broken, but it needs 2 to 3 sittings, the time duration, the expenses, 3 times admission. If you take all these things, we would like to do one shot clearance, which is called PCNL, percutaneous nephrolithotomy. This technique is by puncturing through the back and a 1 centimeter puncture, where we directly enter the kidney and go there with the help of a laser, break the stone into fragments and have a complete clearance in one shot. See, there's one more thing. If the stone is too big, if it is like a stack-on calculi, both the upper calyx and lower calyx is involved, then might be we'll have to do 2 punctures, the middle calycal puncture and the lower calycal puncture, to remove the stone complete clearance. If not, if you could not do complete clearance, the infection was severe or there's some amount of bleeding, you can just leave it, you come back, go inside after 2 days and do the clearance completely. So these are the techniques which are available to us in the modern day practice. So if the stone is not big, it is only the endoscopic method we try to do, a PCNL for larger stones, and very, very smaller stones we would like to wait with time. See, and one thing we have to see that smaller stones mean smaller stones, we think it is 4 mm, 3 mm, 5 mm stones as small as they have to 100% come out. Yes, most of them come out. Some don't come out because of some anatomical defects, or these stones have stuck into the submucosa of the ureter. So you have to give a wait and watch period for some time. If it still doesn't come, I think an intervention is always better, not leaving the kidney to damage. The longer we leave, longer we don't treat properly, it has its own complications of renal damage, which my nephrologist Dr. Gupta would like to explain to you the medical part of it, the medical complications of the kidney, stone complications, and some complications of the surgical also, which he'll be able to talk to you.
So that means that not all stones have common treatment.
No.
So it depends on the location, it depends on the size, it depends also on the probably on the content and the associated infection.
Yes.
Right. So some people are really scared to undergo the surgery. So they always think that the scar will be very big and other things. So what are the latest things which probably can...
90% of the procedure is endourological through the penile urethral passage or the female urethral passage. There is no incision, scar or anything. The other one is what we think is a bigger procedure, is a PCNL procedure. PCNL procedure is a procedure where there is only a 1 centimeter incision in the back. I don't think so big scars are not there. Before, yes, when a pyelolithotomy was done, endoscope, open pyelolithotomy, it's a huge scar of a 15 centimeter incision which was there. And now, if there is a PUJ obstruction, what we can with the stone, we can still do it with laparoscopy. Laparoscopic pyeloplasty with the stone removal, that is also laparoscopic with 3 small hole incisions in the abdomen. Each one might consist about 1 centimeter in size. I don't think so nowadays scar really matters, and there is no scar which is done nowadays. Most of it is laparoscopy, endoscopy. The rarest scars might be if some bleeding occurs or that, or something where we might have to open up. That is the rarest thing we see. And I think it really doesn't consist of more than 0.1% of the patients which are being converted into open nowadays.
Now, how do you do the follow-up of these patients with, who have undergone the procedures?
Okay. So when we are talking about follow-up, so I tell all my patients one theory, like once a stone former is a stone former for the life. So not necessarily this time you had stone and it has been cleared. So what happens next? So the literature says it is 50% chances of having another stone in the next 5 years. So we will tell them whether if at all this is the incidence or the next onset, how can we prevent that? So that is what will be the next thing what we will be discussing on. So how we follow up is whenever we have completely cleared the stone. So we keep always after any procedure we keep something called a stent. So majority of the times we put stent. Some point of time when we feel that it was an easy going in and taking it out, we don't keep the stent. So sometimes we also do something called stentless or tubeless procedure for PCNL. And patient can go home. So following subsequently we call them up for an ultrasound. See every stone has been completely cleared. Or we do sometimes a CT scan just to see that the complete fragments have been cleared. Then we take out the stent. Subsequently, we call them for doing something called there are two ways of following up. One is a stone analysis. The other one is urinary metabolic workup. Stone analysis usually we don't strictly abide by it because the stone composition is majority of the time it is a fix containing almost all chemicals within that. So it will not actually guide us 100%, but it gives a rough idea what is more. Like if at all a particular stone composition 90% is calcium oxalate monohydrate. So we actually know whether this is only because of calcium oxalate.
Sorry to interrupt. So you mentioned stone analysis. So can I know like what type of stones are there? Because not all stones are same as I.
Yeah. Some are the majority of the times is calcium oxalate stones. In that there are monohydrate as well as dihydrate stones. Monohydrate composition is the most majority of the common this thing. Then comes the phosphate stones or the struvite stones. Struvite stones are the infective stones. The infective stones, that's what I was mentioning you. We have to see that the complete clearance of the stone is very much essential for an infective stone. Because if at all we leave some fragments, that will develop into another big stone in the coming 6 months. So patients will be very unhappy. So we have to see that if at all it's an infective stone, we have to follow up with a good amount of antibiotics, see that the recurrence will not happen. And subsequently when I'm talking about that, we also do regular ultrasounds for them to see whether any new stones are formed. Then comes the uric acid stones. It's a very common stones, uric acid. And along with that there are something called cystine stones, which are very less likely in our area of practice.
So that means majority 4 types of stones are there. Calcium stones, and the second is struvite stone or infective stones, third is uric acid stone, phosphorus stone, calcium stone, and then cystine stones. Okay. So based on that, our approach, medical approach also changes. So we need to analyze how and what is the content of that. That is the reason medical therapy or medical management also plays a role. So any patient who has a renal stones, probably we advise certain medical tests also to be undergone. So basic and most important thing is blood parameters. We want to look in for serum creatinine levels, calcium levels, phosphorus levels, and other things which are mineral composition present in the blood. And as well as we want to undergo 24-hour urinary metabolic workup we want to do. For that also probably we'll decide how the next line of management also happens. So just can you summarize what are the things?
Yeah. When we are talking about urinary metabolic workup, it is basically we do 6 chemicals. The urinary, 24-hour urinary calcium, oxalate, citrate, phosphate, magnesium and citrate. So when we see these are citrate and magnesium are actually stone inhibitors. So whenever they are high, they inhibit the stone. The other 4 composition increases the stone formation. So if at all a particular person comes and he says that these are the 4 components which are elevated, we can direct our dietitian, tell her, so try kindly give oxalate reduced diet or oxalate restricted diet, or if it is more uric acid then we say urine free diet. So we can actually direct our goals of not forming stone by doing these dietary manipulations.
So that means to say that diet also plays a very important role in stone prevention or recurrence of the stone.
Approximately only 15 to 20%. Whenever even we do with this amount of dietary restrictions and dietary changes, it is only 15 to 20% of the time it will help. Rest of the things are the genotypic variant.
So, in what special diet you need to advise? Like if common stones are calcium oxalate or calcium phosphate stone, what kind of a diet you recommend to them?
If you ask me, dietary really doesn't work with a lot of patients, and it's only very few people who are too obese and who are completely obese and who are eating meat 3 times or 4 times a day with high protein diet. These are the people we try to tell them to reduce it. I would not tell them to avoid it. I will try to reduce it. The main principles I go back to hypersaturation. I will say take more of liquids. If you know that you're going to eat a little bit or more, drink water a little more. Have some amount of citric acid juices with it, which citrate causes stone formation less. So a number of citric acid juices a little more, water content a little more will reduce it. Still, with all of these things, there are little strands of stone formation still, but it reduces the stone formation in these patients. So, at last, if I can see the summary, it is not only the surgical management of the stone which is required to reduce the recurrency of the stone, it is the medical and the surgical part of the team where the nephrologist and the urologist together combine, and then the results are better. I know still that 70% of the patients don't require anything later, but it is better to analyze and keep it. We don't know who's going to come back, who's not going to come back. A stone analysis, a blood workup with the surgical technique, and tomorrow, knowing all these things, if the patient knows what are the pros and cons of it, he'll be a better person to know what he should eat more, what he should eat less, and how much of water he should drink, and he will know the complications. And so, a overall analysis is better required than saying, I met the surgeon, it is gone and I'm going off. No. It is together, the results are always better. So, like in Aster RV, we have our own stone clinic where all of us are involved in the workup of the patient. Analyze, tell them what is right, what is wrong, what are the possibilities, and what are the pros and cons of it. Then we take a call on a lot of things. Our nephrologist, Dr. Gupta, will tell you more about the diet part of it, because he'll be a better person than that, and hydration also.
So, its main crux of treatment is hydration. So, hydration. That is the main treatment of preventing kidney stones to form. At least it is recommended that at least 2 to 4 liters of water intake or fluid intake has to be there. So, as Dr. Ravish said, we see to it that probably patients should probably pass around 2 to 2.5 liters so that the supersaturation won't happen. But there is a word of caution. Patients with cardiac failure or renal failure should not drink too much of water also. So it's always better to consult your primary doctor and know the limitations. And second thing is, you have to see whether you are at risk for kidney stones or not. Like if you are a diabetic, you have to see that your diabetes should be under control. So diabetes itself will be making your state prone for secondary infection and stone formation. So any diet which you consume more, which is in proteins like heavy meats, red meats, and consuming a lot of fructose rich diet like sugars, salt consumed in a very high quantity also makes calcium to pass in the urine. That also will be making you prone for a kidney stone. So my guidance or my suggestion is to drink enough water so that you should pass at least 2 to 2.5 liters of urine per day. Try to avoid consuming a lot of red meats. Try to avoid consuming colas or foods or fluid contents which are rich in fructose, sugary items, salted items. And if you are doing a heavy exercise or something like that, where you feel that you are prone for dehydration, try to avoid all those activities probably which prevent that. So you have to hydrate yourself before doing all those kind of procedures.
And obesity.
Yeah. So if you are really obese, try to reduce your body weight. And one more thing is, in pregnancy also we see a lot of patients will present with renal stones. We can't do CT scan during those kind of situations. In that conditions, how do you tackle that, sir?
See, the scenario of pregnancy where a stone forms is one, primarily they had a stone before in the kidney which has come down into the ureter causing pain, or during pregnancy because there is some obstruction to the ureter because of the baby getting into the pelvis in the second trimester, there might be spinal stone formations. We like to wait and watch in these patients until the pain increases severely, where that will let's say lead to abortion, or that will lead to something else, or that has led to hydronephrosis and infection. Then we would like to do a small procedure called stunting. Just stunt and come out, and not try to do URS or something, try to remove stones, which leads to chances of abortions little higher. Just put a stone and come out. In the second trimester, it is still safe to do that. So if you do that, the patency is maintained. When she has delivered, then okay, remove the stone at that time. The only thing, if the infection is higher, we try to treat them with antibiotics. Leaving that, nothing else is there.
In this COVID time, so what are the precautions or what special things which probably the patient with the kidney stones have to take?
See, COVID, the wonderful thing, this is a time-specific talking. See, whenever we are at home, now it's all social distancing and staying back at home. So what majority of the people are, we are not doing good exercise. So as we are couch potatoes, so we don't take care of ourselves well. So then the stone formation increases. So there's something called a metabolic syndrome. Metabolic syndrome is attached to, obesity, diabetes, as well as, all those things will bring about increased formation of stones. So in COVID season, we would like to have people to have good amount of hydration. So the other thing, what as Dr. Ravish has also told, dehydration is what is important. Both of us emphasized on that. I always tell my patients at least 150 ml or 200 ml or 1 glass of water per hour. So maintain that hourly intake of fluid rather than some people, when I tell you take 2 liters or 3 liters, they'll take 1 liter or 2 liters in the morning and 2 liters in the evening. That won't help. The kidney requires frequent intervals of having fluid intake. That is what is important during the COVID season. And do a good amount of exercise. And stop a lot of junking. So, junking is what is important. That's what I was mentioning about the couch potato. So stop taking the sugary syrups as well as colas, artificial drinks, processed foods. All these things will bring about stone formation. So taking care of your health by doing a good exercise and good hydration, that is how it prevents kidney stone formation.
One more caution is, a lot of people are consuming vitamin C tablets as a preventive or an immune boosting effect for COVID. So if your doctor has suggested to undergo a metabolic workup like that, it's recommended to stop vitamin C tablets 5 days prior to the test, because it will also give false positive interpretation. So how other lifestyle we can change so that the stones will not happen in the future, sir, for a patient who are at risk for that?
Yeah, same thing what we have already mentioned.
We have already mentioned it's like hydration, physical exercises a little bit. At least I would like to say it's 2.5 liters of urine output, that is approximately 3 to 3.5 liters of water you drink. I think the thing comes down massively. So this is from our nephro-uro team of the Stone Clinic of Aster RV Hospital. We would like to go on with our next meeting after a week or 2 weeks time. This is our simple advice to you to understand what are stones, and there's nothing great in it. Fluid, water is the thing for the treatment of venous stones for not forming. Water form, we say there is surgical procedure and this. For people who are still there, please drink water, though you don't come to us again. Thank you.
Thank you.